Thank you so much. It's a real pleasure and an honor to be here. I've met a couple of you through Skype and other things over the last few years, and so it's been lovely to actually come and visit New Zealand. I've spent about a week here traveling all over the place. I've learned that your highways are very fast and very windy and not a lot of shoulders on them, so I felt like I was going to die when I was driving here yesterday, but I made it. So I'll just start off with maybe a little story, and then we'll get into the workshop. So first of all, I got involved in this area because I had worked in infection control for about 8 years and found that I was getting increasingly frustrated. I would have these great ideas on how to make things better, and I would go to people and try to get them to follow my ideas, and they wouldn't. They would sort of nod in the room, and then I'd leave the room, and inevitably, I'm sure they thought I was an idiot and they wouldn't do what I was saying. And it got more and more frustrating, and I got more and more aggressive with people. You know, you really have to do this. People are dying. We always say that in infection control. You know, there's patients out there are dying, and you're not cleaning your hands, or you're not using the right surgical scrub, or you're not isolating people with C. difficile, whatever it is. And I would get more and more angry. And frankly burned out, really frustrated. And then it was about 5 years ago, I got pulled into one of our patient safety collaboratives trying to decrease MRSA in Canadian hospitals. And part of that involved one of these so-called getting started kits, which you may have seen from IHI in the States. They have all these getting started kits with all the best practices you're supposed to follow. Out of that experience, I met some people who had largely done sort of developing country work using this technique called positive deviance, and learned from them about how I could view the world differently. I actually learned that my biggest problem with bringing about change was me. It was the way that I was approaching things. And if I could approach things differently, maybe I would get the kind of results that I was looking for. That culminates, here we are today, leading a workshop where I'm going to teach you a bunch of the techniques that we use when we engage teams. And the idea will be, at the end of this, you can take these off with you and use them this afternoon or tomorrow. Right? It's not hard to do these things. The hard part is to actually do them. So when you're standing in front of the room, and instead of giving the usual PowerPoint presentation, you actually engage people in a different way. That's the hard part for many people because it feels so uncomfortable sometimes. So I'm going to show you how these work. And feel free to stop me at any point. If you have any questions, just raise your hand or yell and I'll find you out there. But the first thing we're going to do, our first exercise, is called speed networking. And don't do it yet. I'll give you the signal. What I'm going to want you to do is stand up and find somebody in the room whom you don't know very well. And you're going to have about a 2 to 3 minute back and forth conversation about these two topics. Now I've put in there hand hygiene because I know we're focused on hand hygiene. But if you want to put infection control or patient safety, it doesn't really matter to me what you put in there. But the idea, we want a back and forth conversation for about 2 minutes on something you're really struggling with and what you hope to get out of today. And then I'm going to yell switch. You're going to find somebody else and you're going to start your conversation over again. Then I'm going to yell switch a third time, switch again, start your conversation over again. This will take us roughly 10 minutes or so. Okay, any questions about that, or is it pretty clear? All right, so stand up, find somebody in the room who you don't know very well, and start your conversations. All right, everybody, switch it up. Find somebody new. So, I'm curious, what did you hear people saying?
Everybody's got the same problem.
Same problem?
Yeah.
So what might that problem be?
People.
People in terms of not listening, not doing what they're supposed to do, fighting back, pushing back.
On other things.
Yeah, focusing on other things. I'm too busy to do this.
Yeah, behavioural.
Yeah.
They know what to do, but they don't.
When I order that they do it and they overdo it, and but when I'm working in the wards, quite often don't get done as much. You know, when I'm not doing the orders. Do you follow what I mean?
Yeah, I know exactly what you mean. So the Hawthorne effect. You're standing there watching them, and so do they ever get really smart alecky about it? Like, look at me, I'm washing my hands. Yeah, what else? Pardon me? Yeah. So part of it's technique.
Taking shortcuts. That's okay, it's only this once, but everybody does it.
Yeah.
Another lot I find the hardest will be an ethos
Other things you heard?
Not my problem.
Not my interesting. Okay. Do you feel there's a disconnect between what you see as a direct patient safety link between what that person's doing and the health of the patient in front of them? That there's a disconnect where the healthcare workers aren't seeing it. They're just going about their day-to-day business, and this is all sort of an abstract thing that you're talking about rather than a very real threat.
He's been meticulous in theatre, safety out of theatre, that's the same behaviour.
Yeah. Okay. Any other comments?
Our SMOs said that they didn't buy into it because they're medical consultants in the first place.
Ah.
Ignorance. Is that what you call ignorance?
Yeah, that's something that I've heard over and over again. This is a program that's being forced on us, and we had no say. We didn't have a chance to argue with you. It's just some government person's telling us what to do, and so we're doing it. Any other comments?
Where's the evidence that this reduces infection?
Ah, yes, the old evidence question.
Yes.
Yeah, I used to die on that hill regularly. I would fight with people all the time about the evidence. And what I've sort of discovered is that, I mean, that's what evidence-based medicine is all about, right? In that we will not do something or we will delay something because we'll say there's never enough evidence. And so I don't fight with people anymore. What I tend to do is I tend to invite them in to be part of the process and actually talk about it. And it's funny is that oftentimes the question about evidence kind of goes away. It's almost a symptom of people not feeling like they've been engaged rather than a real thing. I mean, if all of you know, if you think about it, it doesn't take a randomized controlled trial to say that you can pass things from patient to patient. That's rather obvious. So I don't tend to engage in that fight like I used to. Any other things?
Maintaining energy.
Pardon me?
Maintaining energy.
Yeah.
Keep it going.
Yeah. You tend to get some bit of a groundswell of support and then it falls flat, or you have a hand hygiene campaign and a week later it's like you never did it. It's sort of sustainability. Okay. Any other last comments? Yeah.
Came through and the people I spoke to was some of the barriers between the infection control team and the frontline staff. You know, sort of putting the curbs around is sort of a very direct, and also just more generally just sort of scurrying away when the infection control team kind of come in, sort of viewing the infection control team sort of kind of policing the and that relationship kind of is
Yeah. That's a very common thing where infection control feel like the police. I've had my staff be called narcs. I don't know if that's a word that's used here in New Zealand or not, but basically, you know, going out and finding people that are smuggling drugs or something. I mean, it's just ridiculous. People think they're funny, but it's actually very hostile to get that kind of reaction from people. And so in doing the work that I've been doing the last little while, what you want to see happen is over time is they greet you when you come on the floor because they're happy to see you, which is it takes a while to get there, but it actually, you can get there, rather than just being seen as, you know, the police that are coming up to tell them what's wrong.
The other comment that we've heard from our doctors is, oh, you've got to be kidding me. I'll be doing my hands all day.
Yeah.
Yeah.
That's a really interesting one. I have to tell you a little anecdote here, which later on I'm going to talk about simple ethnography, which is just a very simple tool of just basically standing in a setting and just watching what people are doing. And when we started our hand hygiene campaign at my hospital about 6 or 7 years ago, our emergency department wanted their own cutoff because we're the emergency department, we're too busy to clean our hands, people are coming in right, left, and center, we don't have time for this, etc. And so if the rest of the hospital had an initial cutoff at, let's say, 70% compliance, we want to have 40% compliance because you have to recognize how busy we are. And, you know, the old me would have gone crazy over that, right? I would have argued with them up, right, left, and center. And the new me kind of said, okay, well, can I see that? So I went down to the emergency department with the medical director, and I had him stand with me in the at the nursing station, and I said, let's just not say anything, don't talk or interact with people. I just want you to stand and watch. So we did that for 5 minutes, and he saw some remarkable stuff. So what he saw was somebody entering in the blood work into the computer, picking up the empty tubes, putting them in their pocket, walking past 1, 2, 3, 4, 5, 6, 7 alcohol gel dispensers, going in the room, hands are still dirty at this point, taking the blood, no gloves, etc., taking the tubes, putting them back in their pocket, walking past 1, 2, 3, 4, 5, 6, 7 alcohol gel dispensers, putting them in the basket to be sent off to the lab. And you saw that in multiple different places. People sitting around chatting, and it was a moderately busy day in the emergency department. But it's not like you're doing battlefield triage here, right? I mean, there is time, but the important part of ethnography is, I know that there's time to clean your hands, but he needed to see it with his own eyes. He needed the social proof that this was something that was actually true, rather than me telling them. It's kind of like raising teenagers, right? You can tell them all you want, but they have to figure it out for themselves, what makes sense and what doesn't. On the basis of that 5 minutes of ethnography, the whole myth about the emergency department not having time to clean their hands kind of shattered. And it shattered in the eyes of the medical director, who suddenly saw, wow, because you know how it is, you go through your life but you never notice things? This forces you to notice things. After that, their hand hygiene compliance started to improve rapidly. I have no idea what they did to improve it, by the way. They did all sorts of crazy things that I really have no knowledge of because it was their ideas and they were enacting them. But they started to improve dramatically because obviously one of their stumbling blocks was the medical leadership, who thought this was crazy and suddenly realized it wasn't. So that's a really neat one, you know, in terms of these things of getting people to see things differently because they're looking at it just from a different perspective. So I can happily tell you that these are universal. I've never led this exercise where somebody has told me that people have too much time. You know, they love the alcohol gel too much. You know, these are very universal challenges. And so recognizing these, it's really important for us to start thinking about strategies that actually go after these things rather than what we tend to do, which is re-educate and re-educate and re-educate. Because nobody really told me that people had no clue what hand washing was. The issue is more, no, they know, but they're not doing it, or they're doing it when I walk in the room, or they're being hostile towards me when I walk in the room. You know, there may be some issues surrounding technique and things, but by and large, this is a behavioral thing. They're just not doing what it is that they're supposed to do. So that was the first technique, called speed networking. I tend to use this with any meeting that I'm leading, rather than getting people to stand up and say where they're from and stuff, which is fun and all, but it's really not getting right into it. And so we kick off meetings by doing this. It is intentional to mix people up, because if you had a mixed group, let's say you were all from one hospital, and you had, a couple physicians in the room. Usually as physicians, I always ask this question. If we were in a hospital and we had invited doctors to the room, where would they be sitting? Near the door? Yeah, I like to joke that they wouldn't actually be in the room because they wouldn't show up, but you can actually, there's some real obvious behavioral things in healthcare that one of the things I like to do when I'm working with groups is actually pointing them out. So I know, because I'm one of those physicians, and I've often sat at the back of the rooms, or I've been on my phone the whole bloody time and not really paying attention, and not recognizing what that's doing to the people around me. It's making it very clear that I don't care, that this isn't important to me. So anyway, speed networking mixes them up. So if you were all from one hospital, we could have physicians speaking with housekeeping staff, and housekeeping staff speaking with pharmacists, and nurses speaking to ward clerks, or whomever. But the idea is you're getting cross-pollination of ideas. And so you're hearing from everybody in the room. Everybody in the room got a chance to speak. Whereas if I just stood up here in the beginning and said, so any comments on hand hygiene, any issues? A couple of you might have said something. You may have noticed in healthcare settings, if there's a senior person, everybody looks towards them to see if they're going to say something first. This you hear from everybody. So it's a very simple technique. You could use this tomorrow. It's just a way of mixing people up, hearing what's going on. We've used this at our hospital. We're having a big push right now talking about end-of-life care. How should we be caring for patients who are dying? And the first question I ask people when they come into the room is a challenge I'm facing, trying to improve end-of-life care for patients and what I hope to accomplish. And you get a real pulse of the room, what people are talking about. And it's usually nobody's talking about we need a better policy or we need better education. It's the fact that it's all about that messy behavioral stuff. Any final questions on this one? It's also meant to be kept short, 2 to 3 minutes per conversation. If you start going on longer, people start to talk about the weather, blah, blah, blah. You need to keep it short, to the point, because you really want to hear those key points. You don't want to get into the weeds.